So I'm going to start with a question. What organization in the United States conducts over 100 randomized controlled trials every day to answer interesting and important questions? Is it the NIH? No. We all know that, right? Is it all of pharma? No, there's not 1,000 randomized trials every day. How about Facebook? Facebook. 1,000 randomized trials every day. So this is an example here. So in big data, this is sometimes referred to in informatics as A/B testing, okay? But these are really randomized trials where companies like Facebook will design two different options, and people will be users will be randomly assigned to one option versus the other, and then they look to see what is our behavior. This is an example from a book called Everybody Lies by Seth Stevens-Davidowitz, where he gives an example of an A/B test that was done before the 2008 presidential election. So this was done by Google, where there were 3 different possible advertisements that people on the internet might be shown, and then there were 3 different buttons that people could click. And then by randomly allocating us, maybe without our knowledge, but by randomly allocating us to one of those options, then they were able to figure out which of those ads is most effective. And so this is the ad that maybe some of you saw before the 2008 presidential election. And how effective was that? It's estimated that by using this ad instead of other similar advertisements, they had 40% more supporters for that particular campaign, worth maybe $60 million in additional funding. So what is big data? Big data means a lot of different things to a lot of different people. And that's what we're going to talk about today. So our objective today is to talk a little bit about what big data is and what role big data plays in emergency medicine from the perspective of education, research, and clinical care. We're going to talk a little bit about some analytic approaches, and we have some guests here today who all view big data through a different lens. And I think that that lens through which they view big data can be instructive for us to learn what that means and how it might be used in our own careers. And then we'll talk a little bit about how we define questions amenable to a big data approach. I don't have any conflicts of interest, and each of the speakers will be presenting their own conflicts. So all of us know about big data. We all have read about Mark Zuckerberg and his views on big data. We know about privacy. We've all been reading about Cambridge Analytica. And the more that this is in the news, the more people are trying to understand, what does this mean for me? What does it mean for my life? Do we participate in big data? Are we being studied? We are. Are we using big data? And right now, is big data improving health and improving the practice of emergency medicine? Those are all big questions. But why is it something that we're talking about right now? I think all of us have heard of Mohr's law. This is a relationship that was first described in the mid-1960s, and it's a relationship between computing power, or the speed of computing, and time. And in this paper from the 1960s, the author made the observation that every 18 months the computing power doubled. And he said, there's no way that can happen forever, right? So here's data that goes up through 2016, and what you see is that it's kind of still happening, right? We have this exponential growth here. We're on a log scale here, this exponential growth in computing power. And so what do we do with all that computing power? Well, we try to answer bigger questions that couldn't be answered without that computing power. The same thing is happening with hard drive capacity. So not only can we analyze data faster and more than we ever could analyze it before, but we can also store more data than ever before. It's estimated now that every 2 years we generate more data as the world than all of humanity since the beginning of time. Isn't that incredible? So what are we going to do with all of it? So what is big data? Couple different answers. If you look at the dictionary definition, big data are extremely large data sets that may be analyzed computationally. Maybe those will reveal patterns, maybe they'll reveal trends, associations, especially related to human behavior. So that's a definition that we can all sort of understand, right? Big data is, something that we previously would have said is not achievable, but now it's just big data. Doug Laney is a consultant in this area who says big data is high volume, high velocity, and high variety information. Many of you have heard this, and there are now some additional V's that have been added by other authors to the end of that. But it's high volume, high velocity, and high variety information that demands cost-effective, innovative forms of information processing. But there's not just one definition. I think that that's our goal today in this didactic session. So our goal is to cover what big data is, how it applies to emergency medicine. We have 3 panelists who are each going to kind of give us their perspective on big data and tell us how they use big data in their own work. Keith Kocher from the University of Michigan, Kevin Ward from the University of Michigan, and Andrew Monte. So Keith, I think that you're up first. I'm going to turn it over to you and kind of let you give us your perspective on big data.
Thanks, Nick. So what I get to talk about is big data in connection to being a health services researcher. And as Nick was saying, you know, we approach this as give us the sort of lens with which you think about so the application of big data to your work. And my talk, I think, naturally is going to spill over into sort of healthcare delivery just because of the nature of health services research as well, so be aware of that. I do have a couple of disclosures to be aware of. I don't think they're impacting sort of any of the work here, but certainly some of this relates to the big data work that I do. So I'm going to be talking about big data to me, but also then sort of sources, applications, techniques, and I think you always have to come at this also with understanding of the limitations around some of these as well. So I don't know if anybody's seen this curve before. I thought it's sort of interesting to think about where big data sits on this. You can find this in different places on Google search. It's from some consulting company. But there's this sense of sort of a cycle of innovation where there's sort of inflated expectations, and then there's this sort of valley disillusionment, and eventually it sort of plateaus again. And big data can be parsed out in lots of ways, but generally speaking, sort of where we fit on this curve, I think is up to the conversation here today. What it really means to me, though, ultimately, is substrate in my line of work. We're talking about sort of quantities of data, lots of observations that you can sort of aggregate together that's really continuously accumulating. I would say like what's really changing for me is can you incorporate sort of more unstructured data, and we'll get into I think some of that terminology here, and the diversity of the data sets that are available to consider linking here. I think the other part of big data that's sort of part of this is not just data as a substrate, but data with the analytics piece that goes along with it. And within those analytics, you get to think about associations and patterns and trends, and in particular, sort of the speed of the processing as you're creating, for example, complex models that you're looking to converge. A few thoughts, again, this is sort of my own bias about this, but I sort of broke this into kind of traditional and non-traditional schemes. But for me, mostly I'm talking about administrative data sets, which either come from claims or derivatives of claim of electronic health records as part of that. And there's some examples there. I would say like increasingly within health services research, there's more, what I'd say, non-traditional sources as well. Social media and e-health and data sets that are sort of outside the typical domains of healthcare that you can link together and create sort of more powerful associations. I sort of broke this out too in terms of applications, the kind of old and then newer types of applications. Old things are about associations and patterns, and particularly between practice and outcomes, but you have limited ability to say something about causality. There's, I think, increasingly measurement around cost effectiveness, comparative effectiveness, but really what's, I think, new and fresh is prediction, and I'll be talking a little bit about some of the tools around how do you do sort of prediction. Again, sort of old techniques around associations, a little bit about causality, but now we have things like machine learning. It's not really new, but it's sort of new in the ways that we're applying it. And effectively, sort of artificial intelligence is just variations of machine learning, which allow you to get at predictions. But let's talk about some of those limitations. So for those that use data regularly, there's problems with missingness and wrong data. I think that's pretty obvious for probably lots of people here. I think, as you start thinking about linking across data sets, you're talking about breaking down silos of where these data sit, and then you confront problems of data security, particularly if you're talking about protected health information, interoperability, privacy. This comes up in a lot of my line of work, actually, with some of my projects. And then people have to be able to trust the data that you're giving them, particularly if you start thinking about predictions. Can you trust sort of how that black box of prediction was run under the surface? And you can see a lot of this in some of the literature where there's sort of this, again, sort of going back to the original curve I showed, where there's belief that things are very sort of rosy, but under the surface there's some potential disillusionment around, if you have biases, for example, inherent in the underlying data, those biases are going to remain there when you go to predict something based on those biases. And that's often times been called big data hubris. So just a few ideas of my own about where these kind of applications sit from these various perspectives as, say, a researcher or a clinician or an educator. I think as a researcher, it's about novelly thinking through these proliferations of data sets and how you can link those together in sort of creative ways. There's certainly efficiency gains in the data processing as well. I think as an educator, you can think about how do you measure sort of trainee skill acquisition, maybe how that predicts future performance of somebody that's out in practice. And I think as a clinician, this is kind of in particular where the rubber hits the road around personalized healthcare. Can you mine the data that sits in an electronic health record system to predict an outcome or a decision, a diagnostic decision based on everybody that's come before you within that data set, generally speaking in sort of a machine learning kind of way. But again, recognizing that that's sort of where those biases may show up in that analysis and that prediction. Here's just a few kinds of thought pieces. These are short, intended to provide a little bit of a sense of things, of kind of current state thinking, both sort of positive and negative kinds of predictions around use of big data in healthcare. I think a lot of these are really good, and a few of them were written by emergency physicians at the forefront of some of these things. So I'm going to stop there and pass the mic.
Great. Our next speaker will be Kevin Ward from the University of Michigan. I'm going to have everybody hold your questions and comments until the end. We'll have about 20 minutes at the end for a panel discussion.
Great. Thanks for the opportunity. I'm going to talk about big data, maybe from a little bit of different perspective, more of a physiologic perspective in terms of using some of that variety of data for clinical decision support. These are my disclosures. So, the big data opportunity for my group is applied to critical illness and injury. And so if you look at critical care, huge healthcare problem. It should be viewed much like cancer. There are, lots of different specialties that practice cancer just like there are critical care. But about 50% of all in-hospital charges are critical care related, and 40 to 50% of all patient days are spent in the critical care unit. And so this is what critical care looks like now. We take a lot of engineers up and they say, Whiskey Tango Foxtrot, what were you thinking? We'd have never designed systems like this. But this is a result of we think we know what we want to measure, we think it's valuable, but we really don't know for sure. And there have really been no game changers from a technology standpoint in over 30 years. So if you look at data, you look at these two patients, they are like opposite ends of the spectrum. A critically ill neonate, 500 grams on a vent, a wounded warrior. But if you look at them from a physiologic or data perspective, they could actually be the same patient. So here's the big data challenge for critical care. So these are some of those V words: volume, variety, velocity, veracity. Just take a guess on a highly instrumented patient in the unit. How many pieces of data per second are coming across? Upwards. No one wants to take a guess? Could be up to 100,000 pieces of data per second. Okay, that doesn't count the genomics and the proteomics. So that's not just big data. That's big ass data, as we call it. So the other part of the challenge we have in emergency medicine and critical care is that you don't have the same team always taking care of you. So data, we're hemorrhaging data. So there's lots of opportunity to capture data that we're actually losing. And so for a lot of us, clinical decision support means having data to make the right decision at the right time for the right patient. So you need data anywhere and everywhere you can get it. So this is, the problem with us is that we can't really track many things at one time. So you've got all this data coming, but we can't track but maybe 2 or 3 things at a time as humans. And so you really have to have the opportunity to perceive the data, comprehend it, and then project it and do something with it. So it's like the cockpit analogy. And you need AI and systems running in the background because a pilot can't possibly look at every variable at every second, every minute, and make decisions. So what our group has done at Michigan is we've developed a system. So right now at Michigan, we are streaming every physiologic signal from every monitor in the critical care units. So all the waveform data, not the integer data, but the waveform data, and banking that and doing signal analysis along with all the laboratory data, all the image data, medication data, building lots of tools to align that data so that we can really come up and use artificial intelligence, which involves machine learning, et cetera, to come up with new systems and new vital signs, new indicators that can help us sort out and keep up with this data. So this is a great example. I'm going to go through a real example of this. And so, part of our problem in emergency medicine and critical care is predicting who's going to go south, who's going to crump. So you don't need big data or lots of technology for people or on the upper part of the curve here. And of course, you don't need big data and lots of technology if someone's got a systolic blood pressure of 60 and laying in a pool of blood to tell you that there's something that needs to be done. It's really all this space in between because the body has really a great way of compensating. And the fact that we've got an epidemic of chronic diseases, I don't even know what new vital or what normal vital signs are anymore. So it really becomes tricky. So we've developed an all-cause, real-time predictive analytic called the Analytic for Hemodynamic Stability. And I'm going to tell you the quick story about how we developed that using some data techniques. So we partnered with the Army to do a hemorrhage experiment in humans. This is lower body negative pressure. So somehow they recruit volunteers to go into this machine here, and they apply negative pressure at intervals, at 5-minute intervals, until they basically faint. All right, so it's pulling blood out of your upper body until your brain can't function anymore, and then they let it go, and that sort of mimics a real-time resuscitation. It's all IRB approved, they tell me. Yeah. But what they do is they monitor high-fidelity vital signs throughout the whole. So continuous blood pressure monitoring, continuous heart rate, respiratory rate. And you can't, what you see here is you can see some general trends, but the limits, the 95% confidence agreements and the intervals make it impossible to use any combination of vital signs at any time to predict when they're going to fall out. So you had big Marines in this thing that fell out at minus 60, and then you had 100-pound tiny females who got to minus 120 and looked at it and said, is that all you got? So again, you really couldn't predict based on a combination of these variables. So we looked at the ECG signal using machine learning. So my analogy for machine learning is Pandora and Spotify, right? So you're looking for patterns in the signal. So we couldn't look at the integer data, so we actually looked at the ECG data to match patterns with responses. And so what we did is we had to get some mathematicians, computer scientists, physiologists involved, and we developed this analytic, looked at heart rate variability, but we used some new math. And so we looked at patterns in there, and like what were the patterns up until the point where that individual sort of fell out and fainted. And so what we're able to do using some new math and machine learning and these pattern recognition were to match heart rate variability to actual changes in lower body negative pressure. So it really, these are pulling out features of that ECG that you could not visually pull out. So a cardiologist could not look at all this ECG data and pick out something that was different. And so this is a case study. So we've now launched this in the background at our institution. And so our approach to this is different from sepsis warning scores. So you can't machine learn your way into or out of a man-made definition. So what we did was prefer not to develop an analytic to predict sepsis because that definition recently changed, right? So what we wanted to do was really machine learn something to physiology, and you'll hear a good term in machine learning called ground truth. And so that's where you've really got to match these patterns to something that's adjudicated, where if you ask 10 physician experts, does this patient have this or that? All 10 would agree. That would be your ground truth. And so here's an example of this. This is a patient admitted for pneumonia and severe sepsis who was intubated. And here his AHI score, this analytic for hemodynamic instability, is in the green section. And then he crumps here, or actually what happens is that the score goes into the red, okay? But his vital signs and stuff are just A-okay. And this, it kind of goes up and down, but for the most part it goes red, and no one's really doing anything. He gets weaned, but so according to all the regular vital signs and respiratory parameters are okay, and they pull his A-line out. He continues to have ECG monitored, and they transfer him to the floor. And then hours later, a code is called to, he's got to go back into the unit and be re-intubated. So this is us taking this pattern that we identified in this army, running this again on additional 100 patients in our data bank, and then launching this behind the scenes. No one's acting on this at the moment, so we're still studying this. But this is, again, an example of how you're taking these patterns in physiology. Now, he had respiratory failure. He got septic again. So for this, we believe the provider will be smart enough to sort of figure out what's wrong, but they've got to have a leeway, and they've got to understand that even though the monitor is saying everything's fine, you're going to look at this physiology based on heart rate variability, which we know is connected to the autonomic nervous system. And so, again, what this is doing is predicting that something's going to happen based on a real-time measure of autonomic nervous system dysfunction, right? So we know that nothing can become good if your autonomic nervous system is unraveling. It will only be a matter of time before you decompensate. So in summary, we're just saying this is a real-time clinical surveillance sort of product that would have hope of working in the hospital, in the ICUs, in the ED, in the wards. It could apply a patch, for example, to take this signal. So this is sampling at 125 to 200 hertz, so that's 200 samples per minute. But that's a different approach. So that's unstructured data in that ECG. And that's big data. So it's continuous. You're running this up in the cloud, and you're running this analytic. We'll layer other things, so lactates and shock index and lots of other things. But again, this is just an approach using physiology and big data to develop something for clinical decision support. My last slide is using this for phenotype. So basically, we're identifying phenotype. So again, going back to the sepsis definition here, anything that has a syndrome name attached to it is bad, right? So sepsis right now is what we say it is. We really don't know what we're treating, but there are probably 10 different phenotypes in sepsis. So going back to this whole concept of precision medicine, this is a perfect opportunity to use big data analytics to really ferret out what type of sepsis you have. So if there are several phenotypes of sepsis, those phenotypes are likely to respond to different treatments. And so again, right care for the right patient at the right time, probably a good use for big data. Just a couple of references. Some of this reflect our work, but some of this is, this last reference is about coming up with real-time risk predictions using big data as well. All right, thank you.
All right, thanks, Kevin. So again, just a reminder, we're going to hold all the questions and discussion for the panel at the end here. Our final presenter is Dr. Andrew Monte from the University of Colorado.
Good, and we'll have a bunch of time for some questions. And so, you know, when Nick first put this together, he started to ask, okay, well, what is big data to each of you? And actually, we spent 2 calls actually trying to agree on a definition between all of us. And ultimately, we said, well, it's actually different to all of us and probably different to everybody in this room. And so we spent time just talking about what it is to each of us because we all work in very different fields, right? So my obligate disclosures, nothing major there, and nobody's paying me for anything in this presentation. So here's a clinical example of the way we think about big data in general, right? So we do precision medicine work, as it was just referred to. So 2 patients with headaches, no big red flags, you know, but only one gets better with the headache cocktail, right? So here are our patients, right? You know, these people are clearly different people, right? Different genetic backgrounds. They're totally different, right? So if we have these 2, one's been there 6 times in the past 3 months, and this is the first visit to the other. I would suggest to you it's very likely, right, their pathophysiology is going to be significantly different between these people, and given some of the variability within their genetic background, they're probably going to respond differently to the medications we give, right? So we need to know what their, you know, what is actually the mechanism behind this symptom, right? There's many different causes of this symptom, and then, you know, how is this individual patient going to respond? You know, different races, different ethnicities, different past medical history, all sorts of different things can actually play into this, right? So why are we giving prochlorperazine and diphenhydramine to both of them? I mean, that doesn't make sense, right? Like, so, I mean, we know that actually half of the medications we give in our emergency department are actually ineffective, right? I mean, think about it. When you guys see somebody with nausea in your practice, you know, how many people use ondansetron first? I mean, I do, right? Most of us do, right? I mean, maybe the rest of you are using alcohol swabs now, but whatever it is you're doing, right? We're giving ondansetron, and it's only working about half the time. Let me pose the question to you this way, right? This patient comes in, and she's pregnant and she's been vomiting a ton. What's the first thing we do? We give them dextrose, right? Like, that's actually probably a more direct treatment for the ketosis, which is incredibly emetogenic, right? And so why are we giving Zofran to all these other people that have bowel obstructions, right? That have, you know, a head bleed, whatever it is. And in this case, right, we know that actually diphenhydramine and prochlorperazine only work in about 60% of the cases, right? And actually 16% get akathisia and dystonia, right? We should be able to actually predict some of this, knowing a little bit more about, you know, what is causing their symptom, actually, and what their genetic background is, right? I mean, we can actually look at that. So what is big data to me? It's data sets with many and just truly a lot of variables. So we, as I said, we do precision medicine work and we look at genomics. And so when we think about that, those are 3 billion different data points in every single person, right? lots of patients, lots of genes, lots of variability in the disease, lots of variability in the treatment, right? And actually that changes with time. People are not, you know, when they first get gastroenteritis, they're not significantly ketotic usually, but actually that can feed upon itself, right? You get more ketones, it's more emetogenic, and so actually the treatment is different in different courses of the disease. I mean, we heard about that as well, right, with some of the sepsis stuff just a moment ago. Clearly we see that in our practice as well. So if you can actually start to put some of this stuff together and more precisely define these phenotypes, and we keep saying phenotype here, then you can actually more precisely treat the disease that you're looking at. The hard part, right, is starting to define what those phenotypes are. And you really need thousands of patients to do that. So this is the way, and this is the approach that we've actually in our group has started to approach this. So what we do is we actually take clinical data from Epic, so discrete clinical variables, and we pull it down from the records. You know, there are limits of this, and we're going to talk through that, but actually Epic is a wonderful tool in this regard because there's a ton of data that you guys know are in Epic. If they're discrete data points, you can pull them right down. Heart rates, blood pressures, all that stuff is actually captured. You have a lot of different things. Medication goes in, you know generally about what time it is, and there's generally documentation as to whether or not people got better. We actually will add in additional data collection tools, right? So we just actually are now implementing a nausea scale into our record so that way when nurses give an antiemetic, they can document how it works and whether or not there was an adverse drug event afterward. So you can actually customize this tool, right, to look at questions that you're interested in for these more common conditions that you want to study. So this is our emergency department here. We're an emergency department that sees about 105,000 patients per year. This is our ED laboratory. And so every single patient that comes in, essentially we actually have the registrars do a self-consent model, and actually we get a tube of blood at the beginning for genomic work. We get a tube of blood for metabolomic work, and then we get a tube of blood at the end of their visit after they've been treated for sort of provocative analyses, right? And then the consent part actually happens separated from this. So we have waiver of consent to actually get tubes of blood when patients actually have an IV placed, because normally they're pulling off these big rainbows, right? And that blood sits there and half of it is thrown away. And so we actually just sort of recapture that, that blood that's going to be thrown away anyway. And then actually when patients want to consent and when they're able to consent, they read through the forms. Our registrars actually go ahead and get the consent, and then we match things up on the back end. And actually we have got a really nice and streamlined system where all this stuff is done by sort of barcode scanning, and so we're actually able to match things up, make sure that we have a signed consent, and then actually store it in barcoded boxes so that when we say, okay, now we want to look at appendicitis, see whether or not there are any metabolic markers of that, or we want to look at all the people that have gotten ondansetron for gastroenteritis early in their disease, we can actually pull those samples out really easily, right? We can sort of pull that out with our Epic data pulls. All this isn't possible without a really big data warehouse, right? We've sort of talked a lot about kind of how you store data. You essentially need to have a data warehouse in order to deal with all this stuff. When we have genomic data, even on a small cohort, so we recently downloaded a whole bunch of GWAS chips for a antihypertensive study. We only were actually looking at 80 patients, and I mean, it required us to actually transfer data on, you know, 100 gigabyte flash drive. Right? Like, I mean, you cannot essentially just send it via email, right? You need to actually have a way to store this and then get it over to where you need it to be. So data warehouses are essential in that regard. This is a Manhattan plot. People familiar with what a Manhattan plot is and what these represent? So I look at these in my work on a regular basis, right? And so what these are each one of these dots are a single nucleotide variant, right? Essentially a point on the genome. And so down here are your chromosomes, right? And so essentially what they do is they actually take the negative log of the significance value. And so the concept there, right, is that actually to be significant for genomic data, we generally think it should be 10 to the negative 8 because there's such issues with multiple analyses, right? You're looking at so many different variants that you're bound to have something significant. And so 10 to the negative 8 is generally the significance level that you need for a GWAS analysis. And so if you do that and do the inverse log of it, right, like the ones that rise up are the ones that are more significant. And so this is what you'll see. So when you sort of see these in journals, right, you want to look at these areas that are high, and these are the ones that are more significant. And so, but you can see how many data points, right, like literally potentially 3 billion data points across the genome here that you could be looking at. And so you need a way to both see a statistic, but you can't actually just look at the data set because you'll never be able to actually pull out that one that has, 10 to the negative 9, right? You need a way to visualize it as well. So actually visualization of these big data, I think, is one of the critical things for being able to, for me to understand it. I'm a visual person in general, but I think that just having the statistical analysis actually still makes it difficult unless you can actually visualize it. I mean, I think all of my mentors always said, hey, when you're one of the first things you want to do is look at the data, and this is still the best way to do it. Look at the data. This is an example of one of our metabolomics data sets, right? Like similar thing, like each one of these is a different metabolite across a bunch of different patients and across a bunch of different timelines. And so it's incomprehensible when you do this. And so actually this brings you to better ways to visualize the data. Manhattan plot is one. We look at a bunch of charts. Actually, Nick has asked us all not to talk about statistics here, so we won't get into the statistical analyses that we use to actually put these together. But so here's another way that we actually deal with big data in order to actually take big data and distill it down to bite-sized sort of patient populations, right? And so the way you can do that is actually make things a little bit more homogeneous, right? This big heterogeneous data sets, you can actually make them more homogeneous. And so this was a power calculation we actually did for one of our early metabolomics studies. And so when we sort of did it for a typical mouse study that essentially had all these mice, right, have the same diet, same age, same genetic background, right? You keep them doing the same exact thing. I mean, really, all these mice are essentially clones, right? You only need 8 mice to get 80% power. Like, that actually makes it really easy, and you see why so many people use mice for these types of genetic data, right? Once we actually went up and actually we advised our studies in humans, that actually do vary quite a bit. You can actually advise and just look at a couple of genes in particular pathways. And so, like, if we're going to say, okay, this drug is metabolized through this, we actually think that these pathways are going to be involved in the disease that we're looking at. Then you can advise it by genes where there's a lot of variability. So, for instance, when we were looking at a gene called CYP2D6, a metabolic enzyme that metabolizes about 30% of the drugs out there that we use. Those common ones like diphenhydramine, haloperidol, ondansetron, hydrocodone, all those ones that we actually know. There's actually a lot of genetic variability. So if you advise your data set by that, I hit the wrong button, then you can actually only need 70 samples despite all this heterogeneity in the population, right? But if you want to do just a completely unbiased look and just do metabolomics with no advisement at all, you're going to need 1,500 samples in order to sort of see something, right? This is why when you actually think about GWAS studies, I mean, really almost the minimum that you need for a truly good GWAS study, a truly good metabolomic study, is about 15,000 people per phenotype for complex phenotypes. So that's a lot of patients, right? This is why we take the approach of enrolling as many people as we possibly can, right? But then actually what that also means is that we're really, really careful in how we define our phenotypes. Has anybody seen the new stuff about diabetes? There's going to actually now be more types of diabetes, right? Like Lancet, the recent stuff, there's going to be now 5 different subtypes of diabetes, right? And that makes sense from a pathophysiology and a treatment standpoint. If you're more precisely able to define a phenotype, you're more precisely able to actually treat the disease, right? so this is the way we do these analyses with big data sets, right? So we take a clinical phenotype, we do GWAS studies, and we actually do metabolomics studies on these large data sets, but then we actually advise one analysis with the other, and we more precisely define these phenotypes. So you're actually able to actually find new mechanisms of disease in this way, right? Like you find these metabolites that are way out of whack, and then you actually go back to the genetic data and you say, I bet you anything there's going to be genetic variants within these metabolic pathways, and you're actually able to identify new pathways, right? This work has been done in sepsis, actually in our, in our field, in emergency medicine, and so you can come up with new ways to predict effectiveness and safety of these treatments based upon underlying pathophysiology and underlying genetic variants. And I put my family up here. So these are my family because they do things in a different way, right? So my kids, this was a ski race day for my kids. And so after the ski race, he says, well, I'm sick of riding lifts. We want to go hike up this thing. And so they hiked up this mountain at Breckenridge after his ski race. He'd been racing all day. And I was like, it just made me think that, yeah, I think we are a little bit different, doing things in a different way. But so this is generally our approach, right? We use population level data to describe and predict individual responses. When we're able to pull these individual phenotypes out, and when I say phenotype, I mean both metabolic phenotype and clinical phenotype, then we're actually able to actually build this stuff in, and the next sort of step is to use some of our ops folks to actually build in that decision support, right? And so that's part of the reason why we build this decision support up front for the studies that we do, but then ultimately we'll be able to actually pull that from the record, right? You know, one of my mentors said to me, so are you guys tracking race in your medical record now? I was like, well, of course, doesn't everybody? You know, that's going to be really helpful for our research standpoint. He's like, yeah, you know, I find it's absolutely useless now. We just actually use sequence data. It's like genes. That's essentially it. And I actually took me a minute, right? But I stepped back and you sort of think about it, right? There's so much admixture, and you see this stuff with 23andMe, right? These people say, I thought I was, from Scotland, and, I'm actually from South America, right? Like that stuff is actually really interesting, and it really actually changes the way we actually should be treating patients, right? So there are clearly limitations and problems with this, right? Clearly. And so a couple of these, right? Phenotype delineation is dependent upon the clinical coding in our medical record. And if you all are like me, I'm not always the best about coding all the diagnoses that I have, or, the timing of when I put that in is maybe after I go home, right? Like, fortunately we have scribes, and so things are a little bit more real time, but it is still not perfect, and we're dependent upon how the coders kind of pull in these diagnoses, which, having done a fair number of chart review studies in the past, it can be an issue as well, right? And so we're limited by that. We hope to mitigate some of that by actually just looking at a whole lot of them, right? And so when, hopefully, but we get back to this bias of the big data that was discussed earlier as well, right? Like if those biases remain and are systematic, then we will never actually be able to remove them completely. So we'll be stuck with that, with this approach. Combining multiple data sets and some across time, some of these data are longitudinal, right? The metabolomic data that we have metabolomic data at when patients get there, but then we actually have it provocative in the ED. And so then how do you actually deal with both, the genomic variants, now actually a metabolomic variant at the beginning, but then actually a second metabolomic variant at the end, right? Like you've got to actually be able to combine single data points as a variable and then this stuff longitudinally over time, and actually becomes pretty complex from an analytic and statistical standpoint. And things are still developing, right? Like, I read a paper probably a month on new ways to do this because I'm not convinced that we're doing it the right way yet. There's a discrepancy between clinical phenotype and the prediction by big data, right? And so that's just simply because we're not actually looking at enough variance yet as well. I mean, that's the fact of the matter, right? So we just did a study where we actually looked at drug-drug interaction to see whether or not it changed the way metoprolol worked. Metoprolol is metabolized by this hepatic cytochrome 2D6, right? And we now know that actually if people are on a couple of other 2D6 drugs, then actually their blood pressure and heart rate doesn't change, right? And so when we sort of think about that, right, like our medical record right now isn't actually telling us to look at those drug-drug interactions. And what if they forget to tell you about that drug that they took, right? Like it actually becomes problematic. So you get genotype-phenotype discordance, you know, from what's predicted by the underlying genotype. And that's an issue, right? Like we actually have to be smart about how we pull this stuff in. It's an issue for us from a big data standpoint. And then we have to reconcile these associations that don't make inherent biologic sense, right? We have to ask ourselves on a regular basis, right? Okay, well, how would that work? We have these data and all this metoprolol data where we're finding all this hippuric acid stuff. When you look at where hippuric acid is there's some stuff with lipid metabolism, but it's actually a bunch of you know, gut metabolite stuff as well. And so you kind of come up with all these strange metabolites and you say, where the heck did this come from? And you actually have to go back to the pathways and see what would make biologic sense. And frankly, we throw a lot of it away. I'm sure I'm throwing away things that are potentially significant, right? Like that's just the bottom line. The gut microbiome is probably doing things that I don't quite understand and nobody understands yet. And so we sort of have to take this stuff and put it back and at some point go back to it when knowledge progresses. But that's all that is necessary, right? Sort of stepping back as a clinician and what we know about metabolic pathways and what we know about physiology and actually saying, does this make sense? Can we potentially actually make a biologic argument for this being significant? Sometimes we can't, right? Like, and we just have to say, maybe in the future. Yeah. And so we're just about done. This is just a picture of our group here. And so I won't spend too much time, but they're wonderful folks that are doing wonderful things and enrolling patients constantly in our emergency department and coming up with great ideas. And that's the references. So perfect timing for you.
Great, thank you, Dr. Monte. That was fantastic. So we have about a little over 10 minutes for some panel discussion. So first we'll open it up to the audience for questions. If you have a question, if you'd like to stand up at one of the microphones and identify yourself and your institution and pose a question to the panel. Otherwise, I have some questions that I would love to ask, but I want to make sure to give you an opportunity to raise questions first.
Is anybody doing any genotyping at their institution right now for clinical purposes? Do patients ever come in with their genotype? We see this sometimes with like factor V Leiden, right? Like with factor V Leiden, and you know, occasionally they'll have some paper with genotyping from a reference laboratory that they'll bring us, or even 23andMe. I've had people come in with 23andMe stuff saying, hey, look, you know, I've got this BRCA mutation. Will you give me my mammogram now? And we're like,
you know, one of the questions that I have, so big data has been in the news a lot lately, especially related to some of this Facebook stuff and the testimony before Congress and some of those things. What do you see as the ethical issues inherent in analyzing data that weren't originally collected for research, and some of the privacy issues, especially around health? Maybe I'll give you each a chance to kind of respond to that.
I guess it really depends on what you're going to use the data for. So, you know, we were really, in our structured data collection system, underwent some severe and rigorous overview for making sure that the data is PHI and things like that. Because again, if we're going to turn everything into a big AI, stuff's got to be de-identified immediately. It's got to go to the cloud to run the analytic, and then it's got to come back identified in some manner so that you can make the decisions. So that all sounds like you can do it in one system, but think about a business model for that. If you develop an analytic and then you try to scale that across, you know, several thousand hospitals. So, you know, anything that goes up to the cloud, can be potentially hacked. And so I don't know that there is a good solution. I think it's all the risk benefit. So patients, look at maybe what the end product is going to be and how beneficial it is.
Yeah, I would certainly agree with that. I mean, I think nobody really has a beat on that, and I think we probably all are coming to terms with the realities of that. And I think particularly with protected health information type data, you just have to consider what the upside is and the risks to privacy and security around that. And I think in particular, the reality with PHI is patients don't really understand the fact that their data is there to be used, and that they don't really always have ownership over it, even though there are protections in place, particularly when you start throwing in, as Kevin was saying, business considerations and commercialization.
Yeah, I mean, I would say that our laws are only so strong, right? That's the issue. We've got a law against, using health genomic data to actually drive insurance costs, right? GINA is a law against that. But then again, that those data are eventually going to get out. Things are hacked all the time. And so, I mean, unfortunately, in some respects, my opinion is that in order to make progress in this, we have to be comfortable with a little bit of that risk, right? That's the bottom line, especially in this kind of field of genomics where we don't understand the genome yet, right? We don't. And inherently, we need to be able to actually link some of this genetic information to phenotypes, and so that means linking it to people. Now, it may be de-identified, so it doesn't have your birth date on it, but guess what? Eventually, that's going to be important because some of the epigenomic stuff are going to depend upon what your birth date might be. And so I think that ultimately we've got to come to a point where we're comfortable with some of that risk and put some structure around what you can and you can't do with those data, but realize that it's never going to be perfect. It's going to be a learning process as we go forward.
That's a great answer. Kevin, maybe you can talk a little bit about, so a lot of times we talk about physiology-based data and improving clinical care. What applications do you see in education for big data techniques or big data sources?
Yeah, so to me, the biggest weakness in the whole healthcare big data is we don't have a science convergence of specialties. So we've got a lot of clinicians who think that big data is going to be helpful and to solve a lot of our pain points, but we don't have enough bilingual, like the clinician scientist who's a great clinician but is also has computational data science skills. And I think even in the data science community, there's a difference between a data scientist and a bioinformatician. So computer scientists will say you're not, bioinformatics is really not big data. And so, a lot of this is really trying to have more real transdisciplinary. So our center, we have struggled to bring in data scientists who will really commit to learning our pain points about critical care. So we had some data scientists that we ran through ACLS course, so they would kind of understand. And they did really good. They knocked it out of the park. But, the problem is in the field of data science, you have methodologists, and they want to apply their methodology skills to every problem under the sun. And that becomes a problem when you're really trying to advance the needle. So I just think from an educational standpoint, I'm not sure I really answered your question, but we have to educate and get more clinicians. I mean, I would love to have more clinicians have better true data science skills, and then more data scientists really commit to learning the problems we face in emergency medicine and critical care.
I think that's exactly right. I think it's a salient point. We talk about it a lot, actually, at our institution as well, right? I mean, you need cross-trained people, but ultimately you need a team of cross-trained people, because I know some genomics, and I know some pharmacogenomics, and I know emergency medicine and toxicology, but I don't know genomics the way my colleagues do, and I'll tell you what, I don't know how to build anything in Epic, so I really lean on our ops people that are quote-unquote trained to be Epic builders, right? And so we really try to actually train physicians to actually do more than one thing. I mean, we are a great specialty to be able to do that, right? We are inherently comfortable doing more than one thing, right? We take care of trauma patients, we take care of medical patients, we take care of kids, and so sort of starting to get comfortable with that in the science realm as well, I think is really important. And ultimately, you got to be comfortable that you're still going to need a team to help fill those holes.
Keith, maybe another question. Oftentimes we hear that big data is here, and it's here to stay. Can you think of some examples that we've seen in maybe emergency medicine, but maybe medicine more broadly, where big data has really already impacted the care that we're providing? And anybody can answer that. It doesn't have to just be for Keith, but not to put you on the spot.
Yeah, I mean, I think, yeah, as we started out the talk here, I think we all have sort of our own concepts of what big data is. It's just a matter of scale and current state. And I think you can make arguments that even clinical decision rules, to some extent, are big data driven. I think sort of the next generation of those they're more flexible, they're more intelligent, they incorporate data that exists already warehoused to be more finely tuned to the particulars of that patient. I mean, that's where I see, for example, one application of the kind of work that I'm involved with is sort of at the point of care in sort of those ways. But I mean, it's all on the sort of shoulders of what came before, which, to some extent is big data too.
I want to say I think it has a lot of promise, but I think overall the big data scene for medicine has been totally disappointing. I mean, we're making hundreds of millions of dollars of investment, and I haven't seen it pay off. I mean, for scoring system or predictive systems like for sepsis and things like that, I mean, part of it is the source of the data and how good the data is, right? So we have patients who are discharged with a diagnosis of pyelonephritis who are actually septic, but we don't code it as sepsis, right? So again, adjudicating these ground truths about what it is. So this is why if you notice every study, no one really does better than an area under the curve of 0.8, right? That's sort of the sticking point. And then you have to call these folks out because they'll report an AUC, but they won't report the positive predictive value and negative predictive value. So we never undertake a study unless we sort of have a predetermined, like, what, if we're going to really embark on this, what will the outcome be from a PPV or NPV that will make people want to use the tool? Because God knows we don't need another false alarm. Okay, so again, this is why you can create an algorithm or some predictive analytic in one system. It looks like it works good, and then it goes to another system, and it totally fails. It goes down from 0.85 to 0.65 because we're not calling the same, we're not defining things the same way many times across systems.
And I'll just sort of, add just as a correlator to that. I mean, when that happens, then I think you're also going to discover that people are not trusting the underlying analytics anyway. I mean, if you're getting different results in one hospital, one system relative to another, because of the sort of black box underneath that hood, I think that's going to be another level of dissemination, is getting over the hump of getting people to trust that result, even if you can do the work.
All right, so that is the end of our time together. I want to thank everybody for sticking around until the end of the sessions on Thursday. Thanks to Keith Kocher, Kevin Ward, and Andrew Monte for being our panelists today. We can give them a big round of applause.